Hi, this is Dr. Akhtar Amin and today's topic is lacrimal gland tumors. 1 in million is the occurrence and it represents 10% of the orbital space occupying lesions. Clinical pearl about the lacrimal gland. There is one orbital lobe and one palpebral lobe. The orbital lobe and palpebral lobe. The lacrimal excretory ducts of the orbital lobe and palpebral lobe, as you can see, pass through the palpebral portion. And so, whenever we take biopsy, it should be from the orbital portion to avoid sacrificing the ducts. Here you can see the tear duct from the orbital traverses the palpebral portion. The anatomy: lacrimal gland consists of myoepithelial cells and glandular epithelial cells. The overall breakdown of lacrimal gland tumors, they are divided into non-epithelial and epithelial. Non-epithelial are 75%. Epithelial are 25%. Among non-epithelial, the most common is dacryoadenitis, non-specific inflammation, and lymphomas. Among the epithelial, 55% are benign, 45% are malignant. Among malignant, the common is adenoid cystic carcinoma. Among benign, the most common is pleomorphic adenoma. Our lecture will be on pleomorphic adenoma and adenoid cystic carcinoma. Pleomorphic lacrimal gland adenoma, also known as benign mixed cell tumor. Most common epithelial tumor of the lacrimal gland. It is derived from the ducts and secretory elements including myoepithelial cells. It predominantly affects young to middle-aged adults. Pleomorphic lacrimal gland has a pseudocapsule of surrounding tissue without invasion. Diagnosis: symptoms: it is a painless, slowly progressive proptosis or swelling in the superior lateral eyelid. It is usually of more than 1 year duration. So the old photograph may reveal an abnormality many years prior to presentation. Now the signs of orbital lobe and palpebral lobe are different. The orbital lobe tumor, it presents as a smooth, firm, non-tender mass in the lacrimal gland fossa with inferonasal dystopia. Posterior extension may cause proptosis, ophthalmoplegia, and choroidal folds. The palpebral lobe tumor is less common. It tends to grow anteriorly, causing upper lid swelling without dystopia, which may be visible to inspection. This picture shows the palpebral gland tumor, and here it is visible on inspection. Now the investigations. The CT shows a round or oval mass with a smooth outline and indentation, but there is no destruction of the lacrimal gland fossa. The lesion may indent the globe and calcification may be shown. Now the treatment. Treatment involves surgical excision. If the diagnosis is strongly suspected, it is wise to avoid prior biopsy to prevent tumor seeding to adjacent orbital tissues. Although this may not always be possible in the context of diagnostic uncertainty. Tumors of the palpebral lobe are usually resected along with a margin of normal tissue through an anterior transseptal orbitotomy. Those of the orbital portion are excised through a lateral orbitotomy. The temporalis muscle is incised, then the underlying bone is drilled for subsequent wiring, then the lateral orbital wall is removed and the tumor is excised, including a margin of adjacent tissue and periorbita. Then the lateral orbital wall and the temporalis are repaired. The prognosis is excellent. Provided excision is complete and without disruption of the capsule. Incomplete excision or preliminary incisional biopsy may result in seeding of the tumor into adjacent tissues with recurrence and occasionally malignant change. Now the lacrimal gland carcinoma. It is a rare tumor. It carries a high morbidity and mortality. In order of frequency, the main histological types are adenine cystic, 50%, then pleomorphic adenocarcinoma, then mucoepidermoid, then squamous cell carcinoma. The peak incidence is in the middle-aged adults. There is no pseudocapsule and the basalite pattern have a 5-year survival rate of 20%. The risk factors. The risk factors are incomplete or piecemeal excision of benign pleomorphic adenoma, followed by one or more recurrences over a period of several years with eventual malignant transformation. The second risk factor is without a previous history of pleomorphic adenoma as a rapidly growing lacrimal gland mass, usually of several months duration. Diagnosis. Symptoms. A malignant mixed cell tumor presents in 3 main clinical settings. So 2 are these and the third one is a long-standing proptosis or swollen upper lid that suddenly starts to increase. So as a long-standing proptosis or swollen upper lid that suddenly starts to increase. The history is shorter than that of benign tumor. Pain is frequent feature of malignancy, but may also occur with inflammatory lesions. Now the signs. A mass in the lacrimal area causing inferonasal dystopia. Inferonasal. Posterior extension with involvement of the superior orbital fissure may give rise to epibulbar congestion, proptosis, periorbital edema, and ophthalmoplegia. So epibulbar congestion, proptosis, periorbital edema, and ophthalmoplegia. Hyperesthesia in the region supplied by the lacrimal nerve, and optic disc swelling and choroidal folds. Here is left proptosis with medial displacement of the optic nerve and extraocular muscles. Investigations. CT scan typically there is solid lesion with irregular margins and nodularity, often with contagious erosion or invasion of the bone. Calcification is commonly seen within the tumor. So there is a globular lesion, irregular serrated edges, and calcification. Biopsy is necessary to establish the histological diagnosis. Subsequent management depends on the extent of tumor invasion of adjacent structures as seen in imaging. Neurological assessment is mandatory because adenine cystic carcinoma exhibit perineural spread and may extend into the cavernous sinus. Treatment involves excision of the tumor and adjacent tissues. Extensive tumor may require orbital exenteration or mid-facial resection, but the prognosis for life is frequently poor. Radiotherapy combined with local resection may prolong life and reduce pain. Adjuvant intraarterial chemotherapy or brachytherapy may be utilized in some cases. Prognosis. The aggressive tumor after initial lesion is treated, 10-year survival rate is approximately 20 to 30%. There is distant metastasis and local recurrence. The basaloid form is the more aggressive tumor. Thank you very much.